Good morning, everyone, and welcome to Medicine Grand Rounds. It's really a pleasure today to introduce two of our own. And because there are two, I'm going to keep their introductions brief. I limited myself to 2 honors each. It was hard to pick among the various honors of these two faculty members. First, Ann Sheehy. Ann took her undergraduate degree at Stanford, having grown up in Middleton and being the offspring of a member of our faculty as well. So Ann is truly in her home institution now. She then went off to Mayo, though, and took her MD at Mayo, and then residency for 1 year in OBGYN at UT Southwestern before seeing the light and becoming an internist and training at Johns Hopkins. Also along the way, in terms of her education, she received an MS in clinical research at Mayo. She came back to Wisconsin as a clinical assistant professor in 2005. In 2010, she was made head of the Division of Hospital Medicine. She track switched to, she actually was promoted to clinical associate professor in 2011, then track switched in 2013 to CHS associate professor, and just this month was recommended by the Biosci Committee to switch again to become an associate professor with tenure in our university. She also serves as the medical board president, with her term just starting this year. Among her awards, she received the Society of Hospital Medicine National Award for Outstanding Service, a national award in hospital medicine. And it's not exactly an award, but it's certainly honorific. I counted at least 3 times she's gone to Capitol Hill over the last several years to represent hospital medicine to both houses of Congress. Now on to Dr. Jaffery. Jonathan received his BA in Russian language and literature from the University of Michigan, took his MD at The Ohio State University, and along the way also obtained an MS in Population Health Sciences from the University of Wisconsin and a master's in medical management, more recently from the Marshall School of Business in LA. He underwent his internal medicine residency at the Fleischer Allen Healthcare University of Vermont system. He took his nephrology fellowship there, and along the way also, just soon after I arrived, did postgraduate work as a Robert Wood Johnson policy fellow in Washington, D.C. Dr. Jaffery came on as an assistant professor at CHS and has been promoted through the ranks to associate professor, and this year became a full professor. Among his leadership positions, he's president and CEO of our ACO, and he's chief population health officer for UW Health. And among his honors, the ACO that he leads is noted by Becker's Hospital Review as one of the 100 ACOs one should know, and even more impressively, he is listed as one of 15 hospital health system population health administrators to know. I don't know what order you're going in, but let us give a round of applause for these 2 outstanding faculty members.
Thank you, Rick, and thanks Ann for putting this together with me and everybody for coming out today. And not to be too self-deprecating, but I think there are only 14 chief population health officers in the country now, so being in the top 15 may not be. So what Ann and I are going to talk about and tag team here a little bit is what you can see beyond Schoolhouse Rock, how a health care bill actually becomes a law. I have nothing to report. I guess neither does Ann. So I'm going to speak for the first 20 or so minutes, 20, 25 minutes, and then turn it over to Ann. And some of our objectives today are to understand the basics of the federal legislative and regulatory processes, so kind of walk through how this works in the real world, know how we as clinicians can really contribute to the process. So I really want to try to get to maybe some practical steps of what people can do to get involved if they're really interested, and then use some case studies to understand how this works. I'm going to talk about something at sort of the 50,000-foot level in what's called MACRA, and then Ann will talk about observation health policy, and I think a little more detail, then I'll talk about MACRA. How many people know what MACRA is? Does that sound at all familiar? So some people a little bit. All right. We could spend the entire hour talking about MACRA. Actually, I think I'm pretty sure you can go places and spend 2.5 days in a conference talking about MACRA, so we'll not get anywhere near that level of detail, but we'll talk about it. The outline for my portion of the discussion will be MACRA at 50,000 feet. And then I want to share with you some insider baseball about how policymakers work, what sort of the day in the life of a congressional staffer is, to kind of help us understand how we might interact with them best, if we're so inclined. And then speak about the gestation of a law. How long does it take for these things to actually get from thought to expression? Because I think it gives us some insights into how very different policymakers work from how clinicians and researchers work. And then just a really practical point about how you might want to work with policymakers, something that we sometimes call the 6-touch rule. So I'll end my portion with a maybe pragmatic approach to working with policymakers. So MACRA stands for the Medicare Access and CHIP Reauthorization Act, because no good acronym doesn't have another acronym within it. CHIP is the Children's Health Insurance Program. So that's a long name, but what does it actually do? MACRA does 3 things. It permanently eliminates the SGR, so that's the sustainable growth rate. I will explain that briefly in a minute. But that's a really important thing to physicians and physician payment. It's been a really important and contentious issue. So this got rid of that permanently, which we've all wanted to get rid of for about 20 years. It consolidates a lot of the quality reporting. There's lots of different quality reporting programs that have come out of the federal government over the last number of years. Some of them are more geared towards hospitals. Some of them are geared toward other things like nursing homes or home health. And then some of them are geared towards physicians. And one of the things MACRA does is to consolidate all the physician payment programs into a single program called the Quality Payment Program. So everything that MACRA has to do with physician payments and physician quality. And then it establishes a path for what's called alternative payment models, or APMs. And that's another thing that, another acronym you might keep in your head, because that's getting talked about more and more, and I think will become more relevant for us as time goes on. So the sustainable growth rate is also sometimes called, or was called, the doc fix. And it was something that got established in 1997 to try and control the cost of Medicare payments to physicians. So there was some concern at the federal level that payments to physicians through Medicare were rising very fast and way above the rate of inflation. And so trying to figure out how could they try and control that, because they were worried that it was going out of control. And so what the law did was, as you can see, it triggered these across-the-board payment cuts. If physician payments, if overall payments exceeded the target expenditures that the government had for Medicare for a given year, then there would be across-the-board cuts the following year. And actually, it could work the other way too. If overall payments were less than expenditures, overall payments to physicians could go up the next year. And in fact, that's actually what happened the first couple of years. This was 97, the economy was booming, and we ended up having rate increases year over year for physicians. I think the first couple of years were 4 or 5% or something like that. It was a reasonable thing. And so at that point, there were no problems, right? People were happy. There was plenty of money, and people were getting raises. But then I think the first year was 2002, where the economy wasn't doing as well. And now we started to see cuts. And so the first year, there were actual cuts to Medicare rates for physician payments. I don't remember the percentage. It was, again, a few percent. And that actually happened. And then the next year, it was going to trigger it again. And people said, well, wait a second. Looks like this is going to happen year over year. We can't cut physician payments 5% or 3% or 6% year after year. People are starting to flip out. Doctors are saying they're dropping out of the Medicare program. Patients are coming and getting upset. So what Congress would do then was every year it would have this, what is called a doc fix, a temporary doc fix. And so it would find a way to say, yeah, we know that the law, SGR, says that we're going to give physicians a 5% payment cut. We're not going to do that, though, and we'll find some way to pay for it. But actually, in the early years, they didn't find a way to pay for it. They just kind of added it back in. And they said, we're just going to delay this. And this started happening year after year after year. And at some points, I think people recognize that Congress, since the early 2000s, has actually become even less effective at getting things done quickly. I don't know if people realize that it wasn't until late Wednesday that Congress figured out how not to shut the government down today. It would have been shut down right now. But they didn't figure out how to keep it open for a long time. It's just till December 9th. So basically, they could come back. They hurried up, passed a continuing resolution so that they could keep the government open for a while. And now they came back, so they can campaign until November. And then they'll deal with it again for who knows how long. So this started happening, and actually, they no longer were just fixing this every year for a year. They'd fix it for different periods of time. I think in 2010 there were 4 or 5 different doc fixes. They'd fix it for a month or 6 months. But every time they would add what's back into the baseline. And so what I mean by that is that if one year was going to be a 5% cut, the next year would be a 10% cut. And the year after that it might be a 13% cut. And they just keep delaying it and keep kicking the can down the road to the point where it became a 25 or 30% cut. So there was no way it was going to happen. Everybody hated this, and we had to have some way to get rid of it. So that's the SGR, and this MACRA totally gets rid of that. So that's a really positive thing that physicians have been fighting for across the board since the 90s, or at least the 2000s. So everyone's very happy about getting rid of SGR, and it's non-controversial that we didn't want it. Nobody liked it. The Republicans didn't like it. The Democrats didn't like it. The House, the Senate, the White House, nobody liked it. The other things that MACRA does is it establishes these 2 program paths. So it consolidates all the quality reporting I mentioned, but it also establishes 2 ways for us to get paid going forward. On the left, you see this thing called the Merit-Based Incentive Payment System, or MIPS. And that's for people who are staying in the traditional model of getting paid fee-for-service. So right now, we get paid every time we do something. If we see a patient, we submit a bill to Medicare, they pay us. If we see 2 patients, we submit 2 bills, and we get paid according to a specific fee schedule. You can keep doing that. The government and everybody across the country, all the payers and employers, are trying to get us away from that. They don't think it's a good system, and the concern is that it incents us to do more and more, whether or not it's valuable to patients, and whether or not it improves outcomes. So under MIPS, you can keep doing that, but you're paid under the MIPS system, and you have to go through a whole bunch of quality reporting. I will not go into the details of that because, again, that's easily an hour itself. But that's one option. The other option is to move into what's called alternative payment models. And there can be lots of different kinds of alternative payment models, but the underlying concept is that providers, whether it's individual providers or groups of providers or large systems, will take risk financially for the care of their patients. So that could be in a system where if costs exceed the expected costs, then we'd have to pay the government back a certain proportion. Or if costs are less than expected, we might get a certain portion back. It could be a situation where a payer gives us a set amount to take care of patients. A capitated payment is what that's called. And then if we spend more than that amount, we lose money. If we spend less, then we make money. But that's the idea behind alternative payment models. And then here's a bit of the timeline. I don't want to focus too much on things, but there's a couple things about MACRA that are important that got us away from SGR that people really hated under the old system. And one thing was certainty. So every year, we didn't know if we were going to get a cut. We didn't know if there was going to be a raise. Nobody understood what the rates were until really the 11th hour, and actually sometimes past the 11th hour. So it wasn't unheard of for some of these cuts to go into effect, even 15, 20% cuts, because Congress didn't pass a change or a fix to it. And in January, our rates would drop. Every single time they fixed it, and they would fix it retroactively, but there might be a month or so where payments went down, and then there'd be a retroactive payment. So there was a lot of uncertainty, and so that was something that everybody hated. So the first thing this does, it establishes certainty. So for a period of time, there's a clear and consistent update to our payments. It's not a lot, 0.5%, but it's understood and it's consistent. And then I just want to focus on here, and I'll come back to this a little bit later, because this is a really key policy issue, and this gets to how the policymakers tried to devise things, and ultimately how maybe we can influence things. But they try to devise things so that it influences behavior, and that's really the ultimate goal of policymaking here. It's quite clear that the government and all other payers want us to go into these alternative payment models where we take financial risk and accountability for overall quality, and want us to stop doing the fee-for-service system, which everyone believes continues to drive higher and higher costs without necessarily any strong connection to quality. What this program does is it takes those two tracks, and after a certain point in about a decade, so it gives people plenty of time to prepare, it gives you a differential update. So if you stay in the MIPS program, you get a 0.25% increase after 2026, and if you go into alternative payment models, you get a 0.75%. Not a big difference, but it's not a big difference each year, but year over year that compounds, and it becomes a significant difference. So for UW Health, after 5 years, this could be millions of dollars. So it becomes a reasonable amount, and it starts to drive behavior towards people recognizing that they really want to be up here. They don't want to be over here. But at the same time, it doesn't have some draconian drop-off. There's no cliff like there was in SGR where suddenly there was a 20% cut and people said we're going to drop out. There was no way Congress was going to allow that. So this way, year over year, Congress could let people, they're still giving them a raise, just not giving them as much a raise as they would get otherwise. So it's designed to push behavior that way, but not do it in such a way that people flee the program. So I want to shift gears for a second, and again, apologize because we could spend a lot of time talking about the details of MACRA. But I want to give you guys a sense of what it's like for a congressional staffer, because it's a very, very, very different life than we have, certainly as clinicians. And I think in all our roles as in health systems, it's very different, but particularly for clinicians. So this is just a screenshot of my calendar from last week, and I'm sure it looks like everybody else's calendar. So super busy, and I don't say this to be braggadocious. So I've been waiting like 3 days to do that. So the point is that when we walk in on Monday morning, our calendar is packed, right? You know in advance that your calendar, what it's going to be like. It may change week to week a little bit, but it's pretty packed week, and it's like that in advance. When I would walk into, so I worked for the U.S. Senate Finance Committee when I was in D.C. And when I would come in on Monday morning, this was a pretty typical way that the calendar would look. You'd have a couple staff meetings that were standing, but your day looked wide open. And this was, so Monday morning, first thing in the morning, this is what it looked like. Friday morning, or Friday afternoon at the end of the day, this is what it looked like. People were, and I see this in the state government as well, the schedule of how people work is just completely different from how we work. And the reason is that things come up, people come in from all across the country to come talk to staff members and come talk to the representatives. And it's an open door policy in the sense that they don't say no to meetings. It's not open door in that you can just walk in and they'll see you. But it gets filled up. It gets filled up every single week completely. And they're talking to everybody across the board. They're talking to all their different constituents. And this is really important for us to recognize because they really have to take into account all these constituent perspectives. So, there could be us as health providers, patient advocates, people from think tanks. They're hearing from people in urban settings and rural settings. They're hearing from the quality folks. And I was struck, it's easy sometimes to come in and recognize that your perspective is important, but they really are having to weigh every single perspective and represent all these constituents. And I'll give you an example. I was there when the first proposed rule for the accountable care organizations came out. People were anticipating this, very well anticipated. It was a very long proposed rule, hundreds and hundreds of pages. And the way that it works is, briefly, is Congress passes a law, and the law might be 2 or 3 or 6 pages, and it says to one of the administrative departments, in this case, health services, these are the things we want you to build in this program. But it's not very specific. And you can imagine a really complex program. They don't get into great detail in 3 pages. And then the government agency then has to come back and come up with really specific rules and regulations around the program. And it can be hundreds and hundreds of pages. And they put out what's called a proposed rule and then allow a period of commentary. So for 60 days after the rule comes out, the proposed rule, people can comment. They can comment in person. There's a process for commenting in writing. Anybody can do this, so anyone can go into websites and put comments in. We routinely put comments in as an organization for a lot of the bigger proposed rules. And then finally, after a period of time, the final rule comes out, and that's how it works until something changes. But when the first proposed rule for the accountable care organizations came out, there were 65 quality metrics, and it seems like a lot in a new program to ask organizations to start tracking. And it turns out, actually, in the final rule, there are only 33, so they cut it basically in half, but 65 at the beginning. And so, as you can imagine, pretty much this whole group came in and said, "You got to be kidding me! We can't suddenly add another 65 quality metrics to our reporting." I certainly was sympathetic to that viewpoint. But the reason I bring this up is because not everybody they're hearing from is saying the same things. And people from the quality departments or the quality associations were coming in and saying the exact opposite. They were saying this does not cover it. 65 is not enough. So at some level, they really do listen to and have to take in all these different viewpoints and weigh them. But it's things that seem so obvious to us, like there's no possible way we can add another 65 quality metrics to our workload, is not that obvious to everybody else, and it's not what they're hearing necessarily. So I want to talk a little bit about this idea of a timeline of a law. This is the gestation of a law that I mentioned early on, and give you a sense of, as Congress is taking in all these different perspectives, how long this really takes. Because again, I think it's a very different perspective than what we have. We have much more of an instant gratification type of job in some ways. You're seeing patients, there's an outcome, you move on with your day. In making laws and in passing laws, the time frame is quite unpredictable, and it almost by definition takes much longer. So I wanted to focus on what I mentioned is this key policy lever, which passed in April of 2015. So it was last year it finally passed. It's just as one piece of this very large law. And I found this. I was going through some old notebooks, and this was a notebook I had when I was in D.C. because I was with the Finance Committee I was in the program from fall of 2010 through summer of 2011. And one of the things that we were trying to work on was how do we get rid of the SGR? Because again, everybody hated it. That was like the golden thing to do. If you could figure out a way to get rid of SGR, that was like the ultimate achievement in the Senate Finance Committee. And so this was notes I jotted down in a small conversation we were having about how do we create a policy lever to get people to deal with the issues around making sure that we don't have a 20% drop-off cliff, making sure that we provide options for people, understanding that across the country, not every organization is going to be ready to move into these more advanced models. And so some of the specifics here are a little bit different, and they're not that important. But it took 4 or 5 years just to get that one little piece in. And I left in 2011. It's years, and you may have an influence on something. Whether most of us are not going to work in Congress, and most of us are not going to run for Congress. But in your role as a citizen, or as a member of a society, or as a clinician, or as a patient advocate, you can have an influence. But you also have to recognize that influence might not take effect for many years down the road, but it still is influencing the shaping of these laws. So before I turn it over to Ann, just a last point or two, another practical point. And so how can you influence policymakers? Again, assuming you're not running for Congress, how can you get involved? Because all of us are in at least this group, but we may be in this group, we may be in other groups too. And so you can have you can have an influence, and there's something that sometimes is called the six-touch rule. And the six-touch rule refers to how many times you need to interact with policymakers in order to have them think of you as an expert or an interested party and start to have some influence. It could be, depending on what your level of expertise is and how much time you're spending in your position, this could be a situation where people start to go to you for advice or for information. But even if they don't, it is a way for just you to get known in that office and start to have influence with that policymaker, and more likely their staff, but those are the staff members are the ones who write the things anyway. And so the idea is that if you can have contact with the policymakers or their staff 3 times a year for 2 years in a row, that really gets you embedded into their psyche enough that you can have more influence than if you're just doing it piecemeal. So it takes a little bit of planning, it takes a little bit of work, and they can be different things. So you can go to the Hill and you can see people, either at the state or the federal level. If it's something that's, if you can do this as part of national organizations. So a lot of our national organizations have Hill days where people fly in, or fly-in days. People fly in and they disseminate people to their state representatives. You can do this as part of advocacy groups if there's an advocacy group that you care about because of your professional or your personal life. But that's one way. You can go to listening sessions, and these representatives all come here. They come here frequently. So this is quite clear. This is Representative Pocan, our representative locally, who this is a couple years ago, but he came and did listening sessions in all these places, and it says stop by and share your ideas and questions. No RSVP needed. So you can just walk in, and that's the opportunity to talk to him and his staff, and tell them what you care about. And then you can go to fundraisers. They love that. You can imagine. But that's another way to do it, and it definitely gets their attention. So, 6-touch rule, practical way, 3 times a year, 2 years in a row, and you're in. And with that, I'm going to turn it over to Ann.
Well, thank you. And I think the most important thing is what Dr. Page has already said. If you can remember nothing about my portion of the talk, besides the point that I did 2 internships, if you're a medical student, don't do that. It's a big mistake. It's painful. So now you can all tune out for the rest of the talk today. So I'm going to talk a little bit about, I'm going to frame my talk about observation status, which I've talked on here before, talk about the Medicare audit and appeals surrounding observation, talk from using that as a framework, my perspective on kind of how a bill becomes a law and a law becomes a regulation, some of the similar themes that Dr. Jaffery just spoke on, and then I'll update you on where we are today on this issue. And I'm going to kind of go through 5 lessons that I've seen in working in this area the last several years. So I basically got interested in observation basically around 2010, and I've talked about this case example before. I had a patient on my service, on one of the GMed services, who had a new diagnosis of cancer, and she had stayed on our service for 3 nights, and she was dehydrated, she had some acute renal failure, she was seen by PT, and she was too unstable to discharge home. And I started talking to our case manager about discharging this patient to a skilled nursing facility. And she said, Ann, she doesn't meet inpatient criteria. She can't go. And I said, what does that mean? She's been in the hospital for 3 midnights, and Medicare has a 3-midnight qualifying rule for skilled nursing facility care. And she explained to me that Medicare was now enforcing this rule called observation status, and that observation nights were considered outpatient nights, and that my patient, who had looked like she was an inpatient, just like all my other patients, actually didn't qualify for this benefit that she needed. And again, this came up over and over quickly. Patients that had paid into the Medicare program their whole life thought they had this skilled nursing facility benefit, and then by kind of a loophole in Medicare payment policy, didn't qualify. So basically what this means, so patients may be hospitalized as inpatients or outpatients. Believe it or not, in a hospital, you can be considered an outpatient. Medicare patients hospitalized as inpatients are covered by Medicare Part A hospital insurance. and Medicare pays for post-discharge skilled nursing facility care. Patients hospitalized under observation are covered by Part B, and there's no skilled nursing facility benefit. So I think lesson number one is that clinicians, frontline clinicians, see the healthcare problems that need to be fixed. And so I think that's the one message that I wanted to bring forward today, is that Congress needs us to come up with these healthcare problems so they can be changed. So what to do? So you can't laugh at this little figure. This took me a long time. But I think it starts with this, the idea or the problem. And that was what I saw with my patient on the wards. And basically what you hope to have happen is that Congress becomes interested in this, and somebody writes a bill, it goes to the House and Senate, it goes through committee work, and then becomes a bill that it passes both houses, both the House and the Senate, goes to the President signs it into law, and then, as Dr. Jaffery stated, it kicks out into the proper agency, and for us this is HHS, and then CMS gets involved in rulemaking, and as Dr. Jaffery stated, then you see, you get to this proposed rule state, and then it becomes a final rule. And in this proposed rule, between proposed rule and final rule, there's a 60-day comment period where you can actually write letters, the institution can write letters, or you can personally write letters and comment on what Medicare is thinking about doing. So as you can see, there's an opportunity to impact this process anywhere along this way, and that's kind of what I'm going to talk about, ways you can do that along that continuum. So to get back to observation, so basically inpatient is covered by Medicare Part A, as I mentioned. There's currently in 2016, there's a $1,288 deductible per benefit period. This covers self-administered drugs in the hospital. It covers the skilled facility benefit that I already mentioned, and that hospitals are reimbursed at a higher rate. Outpatients are covered by Medicare Part B, and while there's this $1,288 deductible, this is a per service deductible. So your patient in the hospital can get billed a $1,288 per CAT scan, per lab draw, per x-ray. Now it's not always that high, that's where that deductible caps out, but there is actually no cap on the number of those deductibles that they are vulnerable to pay, so there's actually no limit to the out-of-pocket payment that the patient may need to make. There's no coverage for self-administered drugs in the hospital, and again, there's the lack of skilled nursing facility coverage. So the financial bottom line, there's a lot of text on here, but this is the way I look at it now, is that observation is like if you went to a cafeteria and you were paying a la carte. If you get just a piece of pie, you're probably, as an observation patient, not going to pay quite as much. But if you go and you get a full meal, you get dessert, you get drinks, you go back for seconds, you're going to pay a lot more. Whereas an inpatient is kind of an all-you-can-eat buffet. No matter what you need, if you need a bypass surgery, if you need a chest x-ray, or if you need a simple stay of just some physical therapy in the hospital, your deductible is the same. So obviously there's a limit on that inpatient out-of-pocket risk for a patient, whereas the outpatient risk is highly variable. It can be little, it can be a lot. So just to touch on the skilled nursing benefit, because I think this is one of the most difficult and challenging aspects of observation policy. The 3 midnight rule, everyone I think is familiar with that who does hospital work. A patient needs to stay in the hospital for 3 consecutive inpatient midnights to qualify for the skilled nursing facility benefit. This law was actually made in 1965 when the average hospital length of stay was 14.2 days for Medicare beneficiaries, or who became Medicare beneficiaries. If you look at data from 2012, that average length of stay is 5.2 days. So clearly 3 days means something totally different than when this law was actually crafted, although the 3 inpatient midnight rule has not changed. And then obviously observation care has greatly increased, especially since 2010. We now have 15% of Medicare hospitalizations at UW Hospital that are observation. Again, something that was totally not present in 1965 when this law was drafted. So again, Medicare was intended to provide health care for seniors. This was the most vulnerable patient population at that time, the most likely to be in poverty in our country, and the most likely demographic to be uninsured. So the goal was to take care of those patients, and now, because health care has changed, we're kind of losing out on some of those patients that the law was intended to help. So the next lesson is that data is important. While the clinical example kind of shapes our mission, I was in the House this month actually, and this was one of the representative offices, and I saw this sign and I loved it. In God we trust, all others bring data. And the other thing to note in this picture is these two 18-year-olds looking guys over here. These are the people that are running Congress and shaping our healthcare realm. So, I mean, they might be 20 or 22, but they're about that age. And I think Dr. Jaffery can attest that this is largely who is staffing these offices. So, anyway, if you're scared now, you should be. But so basically what we wanted to do is we wanted to look at data to support our numbers. And I became curious about how often the observation problem was happening. So what do we know about outpatient hospital care nationally? Well, it's not hard to see in this figure. This is from MedPAC's report to Congress from March of 2016. On the x-axis here, you have fiscal year 2006 to 2014, and on the y-axis, you have cumulative percent change. The dashed line is outpatient visits per fee-for-service Part P beneficiary, and the solid line is inpatient discharges per Part A beneficiary. And obviously, this isn't all observation. This includes all observation stays, but includes all outpatient services. There's been an explosion in outpatient care, 44% increase over this 9-year period of time, while inpatient discharges have decreased almost 20%. So a huge shift in the national landscape and how patients are covered. So we looked at this at UW Hospital, and we wanted to look at how common observation was, and we published this in JAMA Internal Medicine in 2013. And first of all, we wanted to look at where were these observation patients landing? Well, they were largely landing on the medicine services. This blue part of this pie graph right here is the percent of observation care at UW Hospital that was on general medicine service, hospital medicine, and family medicine. 53% of observation was on these services. And at that time, 10.4% of our encounters were observation. And I just told you again, 15% of our encounters now are observation. So there's been an increase. But this is a general medicine problem. We also wanted to look at observation length of stay, and again, this was in our JAMA Internal Medicine publication. Medicare itself states that observation encounters should generally last less than 24 hours, and in only rare and exceptional cases should it last longer than 48 hours. What we found at UW Hospital is across the bottom here, this is all of our observation encounters, this is our medicine, and then 3 other groupers. The blue area in all of these bar graphs is the percent of encounters that discharged in less than 24 hours. The red is 24 to 48 hours, and this yellow is greater than 48 hours. And for all comers, you can see that less than half of our patients discharged in less than 24 hours, which is what Medicare's benefit manual said was supposed to happen. And 16.5% were in this rare and unusual, rare and exceptional category of greater than 48 hours. Clearly not rare and exceptional. The medicine services were even worse. About a third of patients discharged in less than 24 hours, and about a quarter stayed longer than 48 hours. Our average length of stay was 33 hours, all comers, and on the medicine service, 41 hours. So clearly this was not consistent with what Medicare had even intended in their own policy manual. So along came the 2-midnight rule, and this was Medicare's rulemaking to try to fix these long observation stays. And quickly, this is the little bill that we talked about before, we showed before, we realized there was problems with this rule. So again, observation was previously determined by these clinical criteria, which were somewhat arbitrary. And then Medicare moved in 2013 to this 2-midnight rule, where stays that were 2 midnights or longer of medically necessary care would be considered inpatient, and those that were shorter than 2 midnights would be outpatient. So we saw some initial problems, and we published this in the Journal of Hospital Medicine. Basically, 2 main problems. First, patients that were sick enough to be in the ICU who needed 1 midnight would be considered outpatients, regardless of acuity. And we actually looked at our data, and this happened. So this was the patient with DKA that got sick at 2 a.m., and they just basically ran out of their insulin. And just by reinstating their insulin, by actually that evening, they were actually much better. And by the next morning, a lot of those patients were ready to discharge. We also had a bucket of patients that were in acute arrhythmia. So once they were shocked, they were stable, and they could go home. The other thing that was very problematic with this rule is that time of day a patient got sick could impact their classification, and this also happened. patients who got sick, say at 2 o'clock in the morning, would have kind of 22 hours before they hit their first midnight, whereas patients that got sick at 11:59 p.m. would hit their first midnight immediately. And so kind of hinging that on midnights didn't make a lot of sense. At UW Hospital, we found that observation patients that started their encounter before 8 a.m. crossed 2 midnights 13.6% of the time, and those starting after 4 p.m. crossed 2 midnights 31% of the time. So clearly this was the same kind of diagnosis, and time of day basically impacted their billing classification, inpatient or outpatient, and affected their benefits. Let's see here. It's coming up on my screen, but So I'm going to move on to the audit and appeals of this law, which gets us to the Recovery Audit Program, which is known as the RAC. And I'm not going to get into a lot of details here because it's kind of in the weeds, but just to know that the RAC program was established in the Tax Relief and Healthcare Act of 2006 and operationalized nationwide in 2010, about the time I had that patient encounter. And we all know Medicare fraud is unacceptable, but the RAC program was designed to be budget neutral. Congress wrote this so that basically the RACs would basically audit records, and any audit they denied payment for and they won, they would recoup a contingency fee. So it doesn't take too much thought process to know that the more they audited and denied, the more money the RACs would make, and that's exactly what they did. Basically, their business model, if they didn't audit things, they would basically go out of business. So just to kind of put a number on this, we all know the readmission reduction program is really important from a clinical standpoint, but also from a financial standpoint. The RAC program recovered in fiscal year 2013 7 times the readmission recovery penalty. And so hospitals that are really focused on transitions, hopefully for all the good clinical reasons, but for financial reasons as well, kind of were blindsided by how much money they were actually losing in the RAC program. And not surprisingly, there's a huge appeals backlog because once hospitals started getting dinged, they started appealing these audits and payment denials. And basically, in June of 2016, the Government Accountability Office basically said that there was a 275,000 appeals that were backlogged at level 3, which was a 2,000% increase from 2010. Whoops. Sorry about that. Pointers a little bit. A 2,000% increase over that time period. And so there's a lot of things that have happened. CMS has tried to settle these cases. Basically, the OMHA has halted appeals, and then there's an ongoing lawsuit. So again, I'll say any process that looks like this, I've shown this slide before. This is the Medicare audit and appeals process. It's an administrative nightmare, and this is why we really hesitate to put cases out there that are going to fall into this appeals process because it's such a cumbersome process to go through with a long delay, which I will talk about. So we published this study last year, and at the time, developed a 3-hospital collaborative with the University of Utah and Johns Hopkins Hospital, started combining our data to look at what was going on. And we looked at all of our Part A complex audits and appeals at our 3 academic medical centers. And basically what we found was we had over 100,000 inpatient Medicare encounters. We found the RACs audited about 8% of those claims, which was 25% the CMS stated audit rate. The RACs alleged overpayment in about 1/3 of our cases, and the hospitals combined basically contested almost all of these cases. And I will say we contested them because all of the hospitals had a robust process for reviewing these claims up front time and time again to make sure that we felt strongly the designation we placed patients in was correct. The time for cases and appeals was 555 days. We lost about 1% of cases by missing a filing deadline, and I'll come back to this. There's no reciprocal case concession in the appeals process for the government side. And importantly, no overpayment determination actually contested the care that we delivered. So they didn't say, UW Hospital, you shouldn't have done that cardiac cath, or you're not delivering good care for those pneumonia patients. It was all a dispute over billing status. They didn't dispute anything. It wasn't fraud with a capital F as we think about, and that we're delivering care that isn't needed or poor care. It's all, no, you should have hospitalized this patient and sent a bill to Part B instead of Part A. And each hospital spent 5 FTE just to manage this process. So we continued our collaborative, and this is a paper that's under review right now. We looked at all of our appeals reaching level 3, and we had 219 of these cases. 135 had a decision, 71% were favorable. Our days since date of service was now 4.5 years, so 1,663 days these cases had been in limbo. The percent of time that was in the government hands was about 70%. And I just wanted to point out that the government appeals process was missing their deadlines 47.7% of the time. So that meant over half of the time the government failed to meet their statutory deadlines, but the appeals process would march on. And I mentioned that we lost any appeals case that we missed a deadline, so we lost 0.9% of our cases. They basically could do whatever they wanted, which is part of the reason why there's this huge appeals backlog. So the bottom line is there's plenty of material to work with here that needs reform. And so I'm going to go on and talk about how a bill becomes a law and a law becomes a regulation for what I've learned. So again, I think this is my third take-home, is that strategy is really important. As I mentioned before, you can impact this process in the legislative process, and you can impact this process in the regulatory process. What we've done is partnered with our UW lobbyists, our government affairs specialists at Venn, and I've also on the public policy committee for the Society of Hospital Medicine, and we've worked and kind of developed a multi-tiered approach to this issue to visit Congress and talk about these issues. I used to think lobbyist was a dirty word, but I don't think it is. If you're on the good side of things, like our lobbyists are, of course I'm biased, we call them government affairs, not lobbyists. So anyway, so as Dr. Jaffery mentioned, comment letters are really important, and we've drafted several comment letters on these key issues to Congress and to CMS on proposed rules. This one was one that the Society of Hospital Medicine just recently drafted on the MOON, the Notice Act paper form. Again, I mentioned this before, research and data is really important. We have had several wins here. Our data was actually used by the AAMC in a letter they wrote to MedPAC, and then here was Senator Cardin issued an amendment to a finance committee bill, and they cited our paper as evidence for why this needed to be an amendment, and it is part of the bill at this point. So I think data is important, and you can have impact in that way. And then you have to be lucky, and I was invited, fortunately, twice to testify in Congress on this issue, and I think this was also a really high-impact way to kind of change policy. But I think, as Dr. Jaffery mentioned, I think from my standpoint, the regulatory side can be really more impactful. It can bring about small wins. I mean, as we know, Congress can take a really long time to make change, and it is somewhat dysfunctional. That's probably an understatement. When you look at the action that we've had on the legislative side, there's been some bills. This bill has been to count all midnights towards the 3 midnight requirement, whether they're observation or inpatient. And then there is the affirm bill that the Senate Finance Committee has put out. This is where our paper has been used as an amendment. But if you look at the activity, and the Notice Act, I will say, has just passed Congress, and we're working on this from the regulatory side. But the action on the regulatory side has been huge. CMS actually was able to just craft the 2 midnight rule and completely define observation. There's been improved transparency measures issued in the RAC program. The CMS has changed the look-back period for RACs to look at our charts. CMS has serially delayed the 2 midnight rule multiple times, and they've done this just by, kind of with a sweep of the pen and actually instituted these changes. So I think we've had a lot of we felt good about working on the regulatory side. The other thing about the regulatory side, if you're not convinced of what I just told you, is CMS apparently has their own wine, and that's pretty cool. I don't think the legislature has that. So this was they have this wine at Costco. It's not very good. I wouldn't recommend it. So lesson number 5, as Dr. Jaffery mentioned, I think there's multiple touches and contacts are really important in making change. there's almost an infinite number of places to touch and hopefully influence policy, and you need multiple touches to make a difference. And as I've talked about, we did this kind of a multi-tiered approach. And the other piece of our strategy was just to talk to anybody who would listen to us. I wrote blogs, I talked to reporters, and just really try to get this message out, because you never knew who would hear that message and who would also go to Congress and complain to their congressperson that this had impacted them. And what we heard time and time again in Congress was that the AARP had really come on strong for some of these policies, and that constituents had really come out en masse to talk about observation and how it actually impacted them in person. So where we are today, again, I had this slide up before. We feel that there's been a lot of change in observation, especially on the regulatory side over here. Not all of this has been perfect, and not all of these are changes that we would have necessarily designed ourselves. But I think some of the high impact things that have happened have been changes in the auditing transparency measures, some of the delays in auditing. CMS issued this settlement offer to clear the appeals backlog, and actually just last week, they announced that they had actually paid back $1.5 billion to hospitals around the country, including St. Mary's and Meriter. They actually did settle. We did not settle. But this actually helped clear some of the backlog. And CMS has been able to do this just via regulatory action. So how do we know that we've made a difference? We don't. I mean, you never know that all of this work could be for nothing. But I do think we've had some successes that are tangible and show that the efforts we've made have been successful. So I've had the invitations to testify, which I think show direct impact of the work we've done here at UW Health. Again, our research has been used to justify an amendment. The AAMC has used our data to help change policy with MedPAC. I will say Patrick Conway, he's the CMO of CMS. He actually opens my emails. He'll respond. I've actually sent him, every time we're going to publish a paper, I've had permission to send it to him a few days early, to kind of just as a courtesy that this is coming out, because usually they're pretty critical of some policy, and he actually opens them up and says thank you. So it may be some ghost out there that's actually, he has opening his email, but at least those emails are opened. He is a hospitalist, by the way, and I've met him, so I do think he actually possibly is opening up those emails himself. And then right now I'm writing an editorial with Representative Courtney on observation that will go to the Journal of Hospital Medicine. And this is specifically on the 3-midnight rule that Dr. Courtney has been the champion in Congress to get fixed. So in summary, I'll just kind of talk through the 5 take-home points. I think as ground-level providers, every one of you sees how payment policies and healthcare policy impact our patients, and it really is up to us to kind of bring those issues forward. We see these things over and over, and our policymakers don't know unless we speak up about them. I think the individual patient example that inspired me to work on this is really important, but having data to back up your views is also key. Strategy is very important, and like I mentioned, we have our government affairs teams both on the Society of Hospital Medicine side and here at UW Health with Ben. The ability to impact regulation, I think, is equally, if not more important than the legislative process. At least it brings about some small wins while you kind of are frustrated with the long time it takes to see wins in Congress. And then, as Dr. Jaffery also mentioned, change is slow, but consistency, persistence, relationship building, multimedia all do help prompt change. And so just some thank yous to our division, who's been wonderful, Dr. Page, who supported all of my efforts, Dr. Green, who's also supported my efforts, Andrew and Becky, who managed so much of our data. I could not do this without you. Dan Weisberg, who's been my legal counsel, unfortunately just left for San Diego this month. Laura Johnson, who's also always working with my schedule to figure out how to get things done. Bart Capone, who's also been a partner in crime on this issue, and many, many others who have really been very helpful along the way. So thank you.
So here's a perfect example. If you see something, say something. In this case, there's clearly a delay between observing an issue that has a negative impact on our patients, but with persistence, both of you have shown that you can make a difference. Jonathan, please come up, and I'll ask you to call on the audience. All of you figure out who's going to answer each question, or maybe the questioner will identify who they want to answer, and please repeat the question.
Dr. Hogelman?
I sit here wondering, is this conspiratorial? In other words, let's make it so complicated that we want to get rid of Medicare, or was there some decrement in physician professionalism and hospital professionalism? Did we do this to ourselves and have places like in Florida and New York bilking the government, like people seem to not be paying income taxes in New York because they are smart in there, or did we do this to ourselves, or is this a desire to unravel the system?
So the question is, I can speak to this on observation specifically. Did we kind of do this to ourselves, kind of via fraud or kind of workarounds in the system? Absolutely. We hold, and my colleague at Hopkins, he says this all the time when we talk about the audit and appeals process, to remember that Medicare fraud is a national sport, and that we have to be very cognizant of that there are people out there that have worked the system in ways that are financially favorable to themselves, and that we all pay the price for that. I tend to believe, I'm an optimist, I tend to believe that that's a small number of people, but there are a small number of high-profile people that have made this happen, that we've now had this auditing process that's very cumbersome and it needs to be looked at. We hope that, and we've never argued for no audits. I think audits are really important because of that very aspect. We've argued for a more fair, more efficient audit and appeal system so that the bad apples can be found and the people that are actually compliant can kind of be left alone to do their work and not spend money and resources on kind of defending our practice. As our data shows, basically almost all of our cases we win. So it's like, why does UW Hospital continue to get looked at? It doesn't seem like an efficient use of resources to continue to audit us when we've shown that we're a clean program.
Representatives in Congress and senators are very anxious to accommodate their constituents so that you have the best access in terms of contacting congressional members if you're one of their constituents. So in Wisconsin right now, the people that are worth really contacting are the people who are on key committees. And unfortunately, we only have 2 people in Congress now who are on key committees. The most important is Tammy Baldwin. She's on the Health, Education, Labor, and Pension Committee. She's extremely influential in that she's very close to Patty Murray and Elizabeth Warren, who really control that committee from the Democratic side. And if the Democrats take over in the Senate this year, Bernie Sanders will end up as the chair of that committee, and that committee will be a very important committee. Unfortunately, we don't have anybody from Wisconsin on the Finance Committee in the Senate, and the Finance Committee, as John experienced, is extremely important. Now, on the House side, our one person from Wisconsin who's very influential is Ron Kine. Ron Kine is from La Crosse. He chairs the rural caucus of the Ways and Means Subcommittee, and he's a very articulate, effective congressperson, and he is really worth interacting with. Of course, Paul Ryan was the ultimate, but of course now in his current role as Speaker, he's no longer chair of the House Ways and Means Committee. So just kind of keep that in mind in terms of who it's really worthwhile to talk to, because these are the people that really have come and can get things done.
Thank you.
Any final comments?
Thank you.
With that, I want